Bismillah ar-Rahman ar-Rahim. Good afternoon, everybody. As we are near the end of this fruitful conference, I want to congratulate Professor Dr. Tariq al-Zawawi and Professor Dr. Muhammad Subhi for this fruitful conference that cover all points of hypertension and medication and all the discussion points we want to know. Our near last topics is hot topics about hypertension. My colleague, Professor Dr. Sherif Wagdy, will talk about us about strategies for treatment of resistant hypertension.
Mr. Chairman, dear Professor or colleague, we'll tackle now a difficult entity we are facing. Sometimes we are facing with a patient that we cannot control his blood pressure, what we call resistant hypertension. So resistant hypertension is defined as a blood pressure that remains above goal despite the concurrent use of 3 antihypertensive agents of different classes taken at maximum tolerated dose, and one of them must be a diuretic. The diagnosis of true resistant hypertension requires that we exclude white coat hypertension or non-adherence to treatment, which both have been inclusion as a reason of uncontrolled blood pressure. Even patients who are controlled on 4 classes of antihypertension, they are named controlled resistant hypertension. The prevalence of resistant hypertension is unknown, but approximately 10% of patients with diagnosed hypertension, they have a resistant hypertension. The general population, the incidence is low. In specialized clinics, the incidence reaches 15%, but in clinical trials, the incidence of resistant hypertension reached 30% of hypertensive patients. The etiology, we must exclude the pseudo-resistance, as we mentioned before, the improper blood pressure measurement techniques and the guidelines, they stated how to measure the blood pressure clearly in the sitting position. Both hands must be measured, and the patient must be sitting before and not smoking or need to go to any facilities. The poor adherence should be excluded. Patient must be compliant on his antihypertensive medication daily, and of course to exclude the white coat effect, which have been avoided by the home or ambulatory blood pressure measurement. Who are the patients or what are the causes of true resistance? We have high-risk patients, the old age, obesity, diabetic patients, CKD patients, lifestyle, inactivity, high salt intake, alcohol consumption, smoking, drug-related intake of some drugs that have been reported to have a high effect on the elevation of the blood pressure, and of course, secondary causes of hypertension, which leads to resistance in the treatment. The evaluation of patients with resistant hypertension, they should be directed toward confirming the true treatment resistance and identification of causes contributing to treatment resistance, including secondary causes and documentation of target organ damage. This is a steps approach which is recommended by the European Society of Hypertension on how to manage or how to approach a patient with resistant hypertension. The first step is to confirm the treatment resistance, which means office blood pressure should be more than 140/90 or 130/80 in patients with diabetes or CKD, and the patient is already prescribed 3 antihypertensive medication at optimal dose, and one of them is a diuretic. This is the first step. We have to confirm the presence of true resistance. The second step is exclusion, as we said, of pseudo-resistance. Is the patient is adherence on his treatment? Is the patient taking his blood pressure daily? Is the patient is excluded not to have a white coat of hypertension? So this is the second step, is to exclusion of the pseudo-resistance. The third step is identification of some lifestyle factors that may contribute to the elevation of the blood pressure. So if your patient is obese, you should encourage to have a body mass index less than 25. If the patient is having physical inactivity, you should advise him to do regular physical activity, 30 minutes at least 3 to 4 times per week. Patients who are having excessive alcohol consumption, you should restrain from alcohol consumption, as well as the salt intake and low fiber diet, they should be encouraged. And these steps, they seem not so important for most of us, and most of us don't spend time explaining the importance of the non-pharmacological intervention, but actually these interventions has a good impact on the blood pressure control. So as we can see that weight reduction can have a 5 to 10 millimeter mercury reduction of the blood pressure, systolic blood pressure for every 10 kilos weight loss. The diet consumption of diet rich in fruit, vegetables, and fiber and low in fat can reach up to 8 to 14 millimeter reduction of the systolic blood pressure. Reduction of sodium intake to less than 100 millimole per day can achieve a 8 millimeter systolic blood pressure reduction. Regular aerobic physical activity, at least 30 minutes, 5 days per week, can achieve a 9 millimeter systolic. And of course, alcohol reduction can achieve a 5 millimeter reduction. So these non-pharmacological interventions are truly important in management of patients with resistant hypertension. The fourth step in management of resistant hypertension is discontinuation or minimizing the drugs that can interfere with elevation of the blood pressure. Of course, we all know that the use of non-steroidal anti-inflammatory, and especially in Egypt, is high, and this has a direct impact on the elevation of the blood pressure and worsening of kidney function and reduction of the antihypertensive effect of most of antihypertensive drugs. We have different medications. Of course, we have the non-steroidal on the top of the list, the selective COX-2 inhibitor, the sympathomimetic agent as the decongestion and diet pill and cocaine. Some drugs, the steroids, amphetamine, methamphetamine, alcohol, oral contraceptive, cyclosporin, erythropoietin, licorice, and some herbal compounds. So all this medication or all these recreational drugs can also be the cause of resistant hypertension. And we should, before adding antihypertensive medication, to be sure that our patient is not on any of these resistant, any drugs that can elevate blood pressure. The fifth step is the screening for secondary causes of hypertension. Perhaps your patient is having another cause of hypertension that makes his blood pressure not controlled. He might have obstructive sleep apnea, he has snoring, daytime sleepiness, and some apnea witnessed during night, primary aldosteronism, chronic kidney disease, renal artery stenosis, either fibromuscular dysplasia in young females or atherosclerotic in old males, pheochromocytoma, Cushing syndrome, aortic coarctation. All these should be screened when you are facing in a patient with resistant hypertension, and the diagnostic tests are not so hard to do. Sleep apnea can be diagnosed by polysomnography, and the treatment is by CPAP devices, primary dystonism by serum aldosterone and renin activity. You can treat it by surgical resection or adding spironolactone. Renal artery stenosis diagnosed by duplex or CT angiography, and renal revascularization can be a good beneficial tool. Renal parenchymal disease by measurement serum creatinine, drug-induced or heavy alcohol, thyroid disorder. We should exclude all these secondary causes before confirming the diagnosis of resistant hypertension and adding a fourth drug for management of this blood pressure. The sixth step in management of resistant hypertension is adding drugs beyond the three. As we said, the patient must be on 3 classes of antihypertension, and one of them is a diuretic. So what other tools do we have? So pharmacological treatment, the first step, we can exchange the diuretic. Sometimes we can shift the diuretic in the triple combination to chlorsalidone, and this chlorsalidone is known as twice potent as hydrochlorothiazide, which is present in most of the combination for drug antihypertensive. Sometimes we can shift to indapamide diuretic, which is another thiazide-like diuretic, but which is have been shown from several meta-analyses to be more potent in reduction of the blood pressure. And after optimization of the diuretic, as we said from the previous guidelines, combining with ACE or ARB plus a calcium channel block. What fourth-line drug we have? The fourth-line drug therapy we can add for resistant hypertension is the mineralocorticoid antagonist, either the spironolactone or the eplerenone. We have different classes that can be added if we are not controlling after these 4 drugs. We can add the direct renin inhibitor, we can add a beta blocker, we can add an alpha blocker, we can add a central sympatholytic or a direct vasodilator. So these are the main tools, pharmacological tools, we are having to control the blood pressure. So the first step is diuretic plus ACE or ARBs plus ACCB. If it is not controlled, you add spironolactone. This is the 4th line of treatment. The 5th line of treatment, as we said, You can choose between beta blocker, central sympathomimetic, vasodilatic, or an alpha blocker. And of course, we had many data confirming the role of spironolactone in management of resistant hypertension. We have the aspirant trial that have been shown that the spironolactone is effective in lowering systolic blood pressure in patients with resistant hypertension. And we have also another trial which have been shown that treatment with low-dose spironolactone reduced plasma fibrillin 1 level in patients with type 2 and resistant hypertension, leading to its beneficial effect on regression of the vascular remodeling. So the seventh step, what to do? We had the triple combination. We confirmed the diagnosis. We excluded pseudo-resistant. We excluded secondary causes. We excluded drugs that might elevate. And we are taking 4 or 5 drugs, and still we are not achieving our blood pressure control. So this is the rule for intervention and referral for a hypertension specialist. We have 2 documented types of intervention. We have the renal denervation and we have the carotid barostimulation. The renal stimulation, it's boomed in 2014 with the Simplicity trial, and the Simplicity trial was aiming for the Medtronic device for renal denervation, and it aimed for doing renal denervation. And this technique has been documented to have many incremental effect regarding the vasodilatation, release of adenosine, and the release of some beneficial effects that may contribute in the blood pressure reduction. And the result from the Simplicity hypertension showed that after 6 months, there has been a significant reduction of the systolic blood pressure and maintained up to 36 months. After that, we had controlled trial for renal denervation that showed that there were no beneficial effects for renal denervation, and that's why the curve or the role of renal denervation in management of resistant hypertension decreased. But lately, in 2020, we had 2 major trials, the radiolucency and another was the shame control trial, which have been again raised the importance of renal denervation that reached up to 36 millimeter reduction and maintained after 3 years of the meta-analysis of the Simplicity 3 trial. The second intervention for management of the resistant hypertension is the carotid baroreceptor activation, which is another device-based therapy, and it aims at stimulating electrode implanted in the perivascular space around the carotid sinuses. And many trials have been shown that this is a clinically meaningful measure for achieving a systolic blood pressure less than 140 with the use of this technique. And this is the current guideline regarding the management of resistant hypertension. As we can see that we have to confirm mineralocorticoid to be added on top, and the role of renal denervation and the baroreceptor stimulation in this remain in the hand of experienced operator, and diagnosis and follow-up of restricted to hypertension centers, not a routine management as a class 1 indication. Is there any future treatment? We have some future treatment, the creation of venous arterial fistula. We have the neurovascular decompression by surgical intervention, and we have ultrasonic renal denervation. This is a Rox-Koppler device that can be used for creating an arteriovenous fistula between the external iliac artery and vein to increase the arterial compliance and reduce systemic arterial pressure, leading to better control of the blood pressure and treatment of the resistant hypertension. The second technique is the neurovascular pulsatile compression, as we said, surgical decompression of the rostral-ventrolateral medulla in medically resistant hypertension patient, and it has been shown not so beneficial data, so we are still waiting for more future for this treatment of management of hypertension. So in conclusion, this is the algorithm. You should be sure first that your patient is compliant on his medication, he is not having a white coat hypertension, and he is not taking any drugs that may elevate the blood pressure. You should be sure that your patient, when he is on triple combination, including ACE or ARB plus SCCB plus a diuretic plus, they are all at the maximum tolerated dose before diagnosing your patient is resistant hypertension. We should encourage non-pharmacological treatment, as we said, the physical activity, the reduction of weight, the reduction of alcohol, the reduction of salt intake. We should encourage the physical activity, as we said, and we should screen for secondary causes of hypertension. And after that, you add your medication. We can first add the spironolactone, and after that, other medication. If your patient is still after 5 drugs, maximum tolerated dose, then we can have the surgical intervention. The most promising one, or the mostly studied that have data till the date, is the renal denervation. And thank you so much.
Thank you, my colleague, Dr. Sherif. I have one question. The role of low-dose spironolactone in patients with CKD, especially those patients usually they have resistant hypertension. Is this a rule?
Yes, if your patient is having a GFR below 60, between 60 and 45, you can use up to 50 milligram. If the patient is having a GFR between 30 and 45, you can use the 25 milligram, but very cautious and the repeated monitoring of the serum potassium. If the GFR of the patient is below 30, it is contraindicated to give the spironolactone.
Thank you, Dr. Sherif, for a marvelous lecture with some futuristic approaches. I have one comment and one question. The comment is, what is the role of amiloride for resistant hypertension? Does it have a place, or only spironolactone and eplerenone?
It has a place, and it has been mentioned, but I didn't say it quickly. It is mentioned as a class 1 indication after the spironolactone when we are not reaching the target after the triple combination. So there is a big role for amiloride for the management.
Okay, thank you. The other question, this is for you and also for the panelists and our esteemed faculty. I have some patients with heart failure, actually, ejection fractions in the range of 40%, maybe from 35 to 40, with very severe hypertension. For some of those patients, I prescribe Entresto, actually, valsartan and sacubitril, with very marvelous results in terms of blood pressure reduction. Do you think, it's not in the guidelines, I know, but maybe in the future, do you think that resistant hypertension beyond 4 types of therapies may benefit from this pharmacological approach with high-dose sacubitril valsartan 200 milligrams twice daily? This question also for our professors and Dr. Tara, Dr. Mohammed Salim. What's your take on
according to the guidelines, till this moment, Entresto to be used for patients with heart failure, reduced ejection fraction, and currently, after the paper published last month, it has a role in patients with preserved ejection fraction, or what we call diastolic heart failure. But the management of uncomplicated hypertension, severe or resistant hypertension, without any of these 2 indications with Entresto is still off-label, and it is not recommended by any guidelines.
No, but what if you fail to actually control the blood pressure with 5 or 6 drugs? I have some patients on Aldomet, very high doses, doxazocine, and every other type of medication, and blood pressure is still in the range of 170 over 100. I think most of those patients, if not all, have diastolic heart failure. All of those patients have marked LVH. And if you do pro-BNP for those patients, surely more than 90% of those will have a high BNP. And I don't know, maybe sacubitril valsartan will have a role in the future in those multi-drug resistant hypertension.
It might, but till now I think it's off-label.
Yeah, I know. Yeah.
Comment about the use of sacubitril valsartan. يمكن هنا الهارت failure أو patients with low ejection fraction, the neurohormonal factors are elevated. The sympathetic nervous system, the renin-angiotensin system, the inhibition of the natriuretic peptide. In this group of patients, they respond well to the, as regards the hypertension. The hypertension respond well because we attack the neurohormonal factors that lead to rise of the blood pressure. But the resistant hypertension, I think it is another story, and needs trials to prove this. ويمكن أنا يعني سعيد جدا الدكتور شريف إن هو ركز على diagnosis of true resistant hypertension. There is a lot of list or factors دي مهمة جدا. we have to exclude قبل ما نقول ان ده true resistant hypertension. النقطة اللي أنا برضو عايز أسيرها الدوز اوف سبايرينولاكتون. احنا المفروض الدوز أعتقد إن as anti hypertensive هي من 25 ل 50
Yes.
from 25 to 50 ده الدوز اوف سبايرينولاكتون. Ibrinolol, there is no a lot of trials, small trials
Yes.
in hypertension. عشان كده الجايدلاينز حاطط سبايرينولاكتون by name. الحاجة الأخيرة بس اللي هو زي ما أنت قلت احنا بنوصل ساعات ل 5 anti-hypertensive drugs. This patient is considered refractory after excluding all factors you mentioned. If you face such a patient, what to do for refractory hypertension?
I don't have any experience with renal denervation. I don't know if any of my colleague has experience with renal.
السيشن السابقة كنا بنتكلم على renal denervation.
بس I think I don't think مش عارف حتى هو الجهاز available in Egypt. هو كان موجود الجهاز بتاع ميدترونيك كان موجود في القاهرة وكانت يعني كانوا عملوا كام حالة بس ما فيش داتا وما في بس I think العيان اللي حضرتك بتوصفه ده 5 ميديكيشن هو ده الكانديد فور رينال دينرفيشن. ده ملوش حل بس لازم نكسكلود لان في سام تايمز كتير قوي يطلع في اندرلاين كلوز واحنا قاعدين نعالج
وي شود الليسته اللي انت حاططها دي في منتهى الاهميه.
ثانك يو سو ماتش
دكتور شريف. فيري كومبريهنسيف برزنتيشن الحقيقه يعني عرفتنا كل حاجه عن ريزيستنت هايبرتنشن. يعني السؤال الاولاني العيان دول غالبا هياخدوا ايس او ارب زي ما حضرتك قلت وغالبا هياخدوا سبايرونلاكتون. هل حضرتك عندك ريكومنديشن معينه هحتاج اعمل فول اب للبوتاسيوم للعيان ده كل قد ايه؟ ده السؤال الاولاني. الحاجه الثانيه بالنسبه للهيدرالازين، هيدرالازين دايركت فازودايليتور الافكت بتاعه فيري نايس وما بنشوفلوش سايد افكتس. ايه برضه الرول بتاعه في حالات الريزيستنت هايبرتنشن؟ وهل احيانا حضرتك بتكومباين اسايزايد لايك دايوريتكس زي الاندابامايد مع اسايزايد دايوريتكس في نفس الوقت؟
هو اول يعني خلص الكومنت الثاني اللي احنا الرول اوف هيدرالازين محطوط از ا فيفث لاين تريتمنت. يعني بعد ما تحط الايس والاربز والسي سي بي والدايوريتك هنحط الفورث لاين اللي هو السبايرونولاكتون. بعد السبايرونولاكتون عندك بقى اي واحد من اللي احنا قلناهم بيتا بلوكر الفا بلوكر دايركت فازودايليتر الاسكايرين او اللي احنا عندنا السنترال سيمباسومايميتيك. فالهيدرالازين دوره محطوط از ا فيفث لاين بعد الاربعه اللي احنا قلناها. الحته السيفتي بتاعت البوتاسيوم مع الكومباينيشن اوف سبايرونولاكتون والايس او الاي ار بي طبعا as a routine you should have your baseline before prescribing this combination urea and creatinine GFR and serum potassium of the level and you repeat after 2 weeks from the initiation. If you don't have a significant increase of the serum potassium or worsening of the kidney function, you continue on the same dose and you repeat every 4 to 6 weeks. If you have an increase, then you may reduce the dose, and if you have a further reduction, so in this case, you should stop this combination.
I would like to comment on Hydrolyzing also. It is an effective drug, yes, but mind you, 23% of cases on Hydrolyzing can develop lupus nephritis. So it is a drug that can cause drug-induced lupus in up to 1/4 of those cases. And I have one of my cases actually was on slow aprezoline maybe 20 years ago when it was available. And in the follow-up, she was a female. She started to have some joint pains, and she was referred to a rheumatologist who did ANA analysis and anti-DNA, and they turned positive on Hydrolyzing. So we have to take care of Hydrolyzing. Actually, it causes severe postural hypotension. It can cause salt and water retention markedly, and it can really induce actual heart failure in patients who have borderline ejection fractions up to in the range of 50%. So we have to be careful, and that's why it is a fifth line therapy actually. It's not in the front line.
Excellent طبعا like always شريف البرزنتيشن. انا قبل ما انقل على ابني دكتور احمد تاج عندي كومنت صغير بس. انا كنت فاكر يعني انا يمكن طارق يشاركنا الموضوع. انا كنت فاكر ان اللايف ستايل موديفيكيشن يعني اللايف ستايل it is not a true resistance. يعني احنا دايما كنا بنشتغل الاول نبتدي بلايف ستايل لمده معينه وبعدين نبتدي الدراجز. فانا استغربت ان هي تبقى وسط الترو ريزيستنس. يعني الترو ريزيستنس بالنسبه لي ناخد ميديكيشنز وخلصنا الفتره بتاعت اللايف ستايل، فدخلنا في الميديكيشن ففي ريزيستنس. فهل عندك كومنت على ده؟
ما هم حاطينها بيه من ضمن الاسباب ان هي تخلي الدراجز، ما هو انت يو ار جيفنج ا تريبل ميديكيشن والعيان عمال ياكل مخلل وحاجات جبنه قديمه، ف نو واي هي ويل بي كنترولد. فقبل ما نعتبره ريزيستنت ونجيف هيم مور ميديكيشن هي شود كنترول هيز سولت انتيك. هي معقوله واحد فيري اوبيز 35 البودي ماس انتكس بتاعه ما بيتحركش وما بيمشيش، برضه ده بيبقى ليه امباكت. فوي شود انكارج ذيس لايف ستايل موديفيكيشن.
ده اللي نبتدي بيه يعني.
بالظبط بالظبط. يعني جو بارallel. يس.
ثانك يو فيري ماتش شريف. ثانك يو. طبعا هم كلنا بنتخانق علشان نقدم دكتور احمد تاج.